You, Deepak, and thank you, Ruchi, and thank you, Sintis, for having us here. And Kuresh, if you're okay, then we'll go ahead. Yeah, okay. So we will. The idea is to give you some interesting cases and let you scratch your brain a little bit because I know it's post lunch. You all tend to sleep, so we won't let you do that. And this is the first thing that I just want to share with you that. A 57-year male walks into us, our OPD, and he has got less vision in the left eye since childhood. Wearing glasses, no past history of eye problems. He actually never knew that he had this thing. His best character category was 6'6" and 6'18". Left eye had a cylinder over there. Rest of the things were normal, the pressure anterior segment. But what was interesting was the disc. And he had no clue about it. So you can see what a deep cupping with superior notch, and similarity with that, there is a inferior field loss. Similarly, we had a tilted disc in the left eye. Now this is the eye which had the less vision. And again, symmetrical to the inferior notch, you have a superior field defect. So it all fits into a beautiful case of glaucoma. Problem being that the pressures are in a nice diurnal variation done, the pressures are varying between 14 to 80. The corneal thickness is normal. So what exactly are we dealing with? Are we dealing with normal tension glaucoma? So we took a detailed history, whether the patient had at any time steroids, which would have damaged the nerve and then stopped it. Any history of trauma resulting in massive blood loss, which can result in something like this. Any serious abnormality, because I've seen patients who had undergone a bypass ending up like this. No, there was no history of stroke or any other neurological problems. And we did a huge cage of investigations, including 24-hour BP recording, hemogram, ESR, lipid profile, carotid Doppler, MRI, you name it, we did it. And then we decided, all right, nothing is coming out, so we will put the patient on travoprost. And that we started and told the patient to come back after 3 months, so we'll see what's happening. Very nicely, as a lot of Indian patients do, he walks back after 26 months. But the field, the disc, everything was same. And I was very happy, and I whispered in my juniors' ears, "Dekho kitna acha treatment. The treatment is so good, everything is same." And then the patient quietly says, "Sir, but मैंने तो medicine 3 महीने बाद बंद कर दिया था. I have not used the medication." So it is really very tricky. So are we right in starting the treatment, or the patient was right in stopping the treatment? So how does it matter? Whether it is NTG or is it OAG, should we always treat? The problem is that NTG, everything is slightly different because it is a diagnosis of exclusion. It is an unknown entity where IOP is not the major player. So there are other factors that we have to look for. And that is why we did all these investigations and sat down there and took the detailed history to try and figure out what it was. So the first confounding factor could be intraocular pressure. Is it that we are recording it wrongly or something like that? But we have done it very meticulously. There was a correct technique, corneal correction factors, yet all the IOPs were normal. What about the disc? Because if you have a bad disc, that bad disc will reflect in a bad field. And even if it is not glaucoma, you might think it is glaucomatous. So you have to be very, very careful about that. Are we dealing with a myopic patient? But it was not. Was it a disc coloboma? Was it a disc pit? Were there some retinal problems like BRVO, etc., which can again give you fields like that, or an ARMD? But we had checked that out. Sometimes even a pituitary tumor can give a compression, and rarely you can have not exactly like that, but you could have cups like that sometimes. Could it be an intermittent ACG? But we did our gonioscopy and we found out that nothing like that was existing. So we had to rule out all these problems, which we did. That is nocturnal hypotension, perfusion pressure was not bad cardiac decomposition was not there. There was no arrhythmias. All these things can reduce the blood flow to the eye and cause a damage, whereas the pressure may be normal. But we had to look it up. And like we already talked about this, out of which I think Bosner, Schwarzman, and Pigmenti talked about two things that we didn't talk about. So they can also give rise to this. So the NTG study had done, and what I really want to show is that 40% in this study were okay without treatment, and 40%. So that's a huge number, and 20% progress despite therapy. So NTG is a very, very tricky problem. So do we treat it? Risk of progression of visual fields is not related to the severity. But again, it can be related. It is not related also to age, hypertension, diabetes, or family history of glaucoma, but it may be related to migraine, disc hemorrhage in female, none of them happening in this case. Whom to treat is the important thing that we have to discuss. The cost is prohibitive because for poor patients in India, PGR analogs would be perhaps the best thing to do. But if the patient is poor, we may have to think of TRAV also because the pressures are so low. In this case, there was a thing which was threatening fixation. Okay, there's a field test which is right there, both the eyes. The IOP is in the higher ranges. There is a disc hemorrhage. There's a field deterioration. So, what are we looking at? Softer signs would be a wider diurnal variation, new optic disc hemorrhage, deep localized notch, younger age, systemic hypotension, vasospasm, myopia. So these are some of the things that we need to discuss. I think I'll stop sharing for some time and then we'll discuss. I think Manish, you can go ahead and let us know what would be your approach to